Hello, this is a community project for PhySci121 at UCLA, and my name is Evelina Gromilina, and my partner's name is Anna Lee. This video is a series of informational interviews done with the Neuromuscular Clinical Team at the UCLA Center of DMD. We decided to interview as many members as possible in order to express how DMD treatment is incredibly collaborative and that it takes many experts with different backgrounds and experiences in order to treat DMD in the most effective ways possible. We hope that this video will help shine light on the ways DMD varies from other diseases, and that those who watch this leave with a greater appreciation of the caregivers who work together to treat those with Duchenne Muscular Dystrophy.
So our first question would be, like, how would you describe your day-to-day working in your specialty?
So I am a neuromuscular doctor. So neuromuscular is a branch or subspecialty in neurology. So in neurology, we have two big categories of diseases. Well, that's at least the way we categorize them. One is the central nervous system, which includes the brain and the spinal cord. And then we have the peripheral nervous system. Everything that starts in the spinal cord, anterior horn cell, and distal to that, which means the nerves, the nerve roots, the neuromuscular junction, the muscle. These are all included in the peripheral nervous system or neuromuscular category. So as doctors of neuromuscular subspecialty, we usually deal with things that are distal to the spinal cord. However, you can't make that, clean cut, and there's a lot of overlap. There's a lot of diseases that affect both. For example, ALS affects the central nervous system also, or there are some diseases that affect both the central and peripheral nervous system. So I usually, I'm running the Duchenne Muscular Dystrophy Clinic for teenager and adults. It's run every one day a month. And we have another clinic for Duchenne that's more for pediatrics. Dr. Perry Shea, my colleague, he runs that other clinic. We kind of share, and there's overlap. Some people, come to one or the other, and sometimes they go back and forth occasionally. And then we also, if I were to kind of, let me just finish the classification and I go more focused on DMD. So in the neuromuscular world, we have people who only focus primarily on ALS, for example. Some people focus very on peripheral neuropathies, being diseases of the nerve, and some are very specialized on muscle diseases or neuromuscular junction. So there's kind of, again, more subspecialization after the neuromuscular medicine, which is still a category of neurology. In neurology, we have doctors who see stroke, doctors who see Parkinson's and MS. So there are all these subspecialties. So in the neuromuscular category, diseases of the muscle are categorized into two big groups. One is the genetic diseases of the muscle, and the other one is the acquired diseases of the muscle. So I'm seeing pretty much everything in neuromuscular, almost. I'm not limiting myself to one of those. It's not very practical. I'm more of a clinician. But I have more interest in muscle diseases. And so that's why I'm doing the muscle clinic.
So I'm a pediatric cardiologist, and I take care of patients with heart failure and cardiomyopathy and heart transplant. And so part of what I do is work in the neuromuscular clinic, and neuromuscular disease because heart is a muscle too. obviously can be manifested by heart disease, specifically cardiomyopathy. And it's not exclusive to Duchenne. Other neuromuscular diseases have cardiac manifestations too, but the manifestations in Duchenne are pretty typical. And so I follow the kids starting when they're usually around the time they get diagnosed, and I follow the kids in that clinic and take care of their heart disease. In addition, I do some work with cardiac imaging in cardiomyopathy and in muscular dystrophy because the cardiomyopathy is so typical and it follows the very similar progression, maybe a little slower in some patients, a little faster in other patients, but it has a pretty typical kind of progression. It's a very good disease if you're studying how cardiomyopathy presents in the heart and what the changes are in some of the mechanics and things over time. It's a good disease to follow because it follows a pretty predictable kind of pattern. So I do a lot of research with MRI physicists who do cardiac MRI imaging research, and some of the folks, some of the things that they're interested in would be like some of the mechanical features of how the heart moves and some of the tissue characteristics of how the tissue acts, as it scars, as it's damaged, as there's more fat located in muscle, things like that. So that's one little piece. And then the third little piece of what I do is clinical trials for specifically the heart manifestations of muscular dystrophy. And so there are some medications where, because the MRI is a good way to follow the cardiomyopathy, to follow the muscle disease. If you use MRI and follow the heart disease, you can see if the drugs have any effect on the disease. And so there's several drugs that are have been tested in cardiomyopathy associated with muscular dystrophy. And so, so I do those clinical trials.
Do you also work with carriers who might present some kind of cardiomyopathy trait while not being affected by DMD?
So I'm a pediatric cardiologist, so I mostly see the kids, but definitely when I see the kids, I see their moms. And so I always check to see if the moms are carriers or not, if they've been tested and they know that they're carriers, or if they haven't been tested at all and just have to assume the worst, that they could be carriers and should be treated, as the worst case scenario. So I make sure that they know to get cardiology screening themselves. And so it doesn't come up that I have a lot of moms that I help to treat, but I do help to refer them to somebody who can treat them if they have any abnormality or any concerns. And otherwise just make sure that they get screening, even if they don't see a cardiologist themselves.
Our first question is, could you describe your day in the life of your specialty and what do you do?
Oh gosh, sure. So I'm a heart failure specialist. So I'm a cardiologist, an adult cardiologist. And I specialize in patients who have disorders with their muscle. So that can be a heart that is too weak, or a heart that's too thick, or too stiff, or infiltrated with different proteins, all sorts of things that can happen with the muscle. And try to help patients either live with them as best as they can, prevent them as best as we can, or if there is no other options, we can think about replacing the heart. So I'm a heart transplant specialist as well. So that's part of my role, is figuring out when the time is to change the heart. And if patients aren't good transplant candidates, or if they don't have enough time to make it to transplant, we also help find the right match in terms of different machines that can be implanted into their heart, things called left ventricular assist devices, and try to fit the right tools to the right patient and make sure that everyone's kind of looking out for helping them live the best life they can. My day-to-day life is very different. It's just, it's different every day. Right now I'm in the ICU, as I mentioned to you. So yesterday was a particularly bad day because one of my patients who got a heart transplant 7 years ago decided to stop taking her medicines because she was having a difficult time at home after her dad passed away. And so she came in at 1 a.m. with very bad rejection of the heart. So we were up with her for a few hours trying to stabilize her. But I did get home for an hour and a half of sleep. So I am very alert for this video recorded meeting. So yeah, and so it's a lot of back and forth. So you're in the ICU, and then maybe you go to clinic. So I saw some patients in clinic today, and then I was able to come home and have a nice salmon dinner with my wife and daughters. And then I get to spend time with you. So just kind of a good day.
Like, what is your day-to-day in your specialty? What kind of stuff do you do? What are your responsibilities and like, et cetera?
I'm a pulmonary critical care and sleep medicine doc. So recently, in the last few years, I've kind of phased out the hospital work. So I'm not doing as much critical care, ICU. So I'm mostly on the outpatient side, doing pulmonary and sleep medicine. The reason I got involved with DMD population is the Center for DMD that Dr. Shea and others have been setting up. They really needed a pulmonologist, and it kind of makes sense for that pulmonologist to also practice sleep because essentially when there's issues with respiratory muscle strength and respiratory muscle fatigue, actually we're able to identify that probably first in sleep, identify as disordered breathing during sleep before it's apparent, maybe during the day. And then the treatment is, to provide support, ventilatory support, non-invasively. So there's some data suggesting if you do that earlier on, you have some improved outcomes. So that's how I kind of got involved. A lot of the cases of the young men with DMD in particular, their respiratory issues become more prominent kind of after they become non-ambulatory, so in teenage years. And so one of the things that we would do in the clinic based on our experience and the input from other centers is really when one of the patients becomes non-ambulatory, is having stroke. Then we would start kind of doing sleep studies, to determine is there any sleep disorder breathing. Certainly we will do it sooner or adjust that if there's an obvious symptom. But the issue is with a lot of sleep disorders, symptoms are not apparent, and people are asleep, so they don't always know what's going on. So we often will do sleep studies, in their teenage years, monitor not just their breathing, oxygen levels and breathing patterns, but also carbon dioxide and things like that. And if there's evidence of either obstructive sleep apnea, which is quite common in this group as well, or hypoventilation, shallow breathing, we treat at that point.
Oh, that's interesting. I haven't really heard much about like sleep medicine, which I think is
it's sleep medicine is a little bit late in the game. There's a lot of reasons for that. Probably the biggest one is it's hard to study sleep. And so really, I give lectures to the med students and residents. It's been a while, but basically since once they had EEG, so 1920s is when EEG, electroencephalogram kind of developed, and so you can study brain waves. And that's when they were really starting able to identify different patterns, and sleep wasn't just the absence of wakefulness. There was specific stages in sleep, both characterized by EEG as well as other features. And so that's kind of how the field started. Interestingly, clinical sleep medicine was really kind of pioneered by the psychiatrists, primarily interested in dream research, wanting to understand what is the content of dreams as it relates to psychiatric disease. Right now, if you want to be a sleep specialist, you do residency, and then afterwards you do a fellowship in sleep medicine. It's a dedicated year. Typically, people out of primary care, internal medicine, family practice, pediatrics, or specialties, pulmonary, neurology, ENT, and psychiatry are the ones who generally practice sleep. So, I see all the patients individually, meet with their parents, review their sleep studies, talk about, treatments. In addition to addressing kind of the sleep issues, like I said, respiratory problems are common in this group, and an acute pneumonia can put them in a situation where they're not able to breathe and can be life-threatening, and so they can end up requiring intubation, mechanical ventilation in those types of settings. So one of the things we often do, in addition to addressing the sleep issues, is, and looking for common disorders, is provide what we call airway clearance therapies, so a cough assist device. So literally, when the respiratory muscle strength is compromised to the point where the young man can't effectively cough or clear their secretions, that predisposes to occluding the airways, predisposes to pneumonia. And so the machine is exactly what it is. It's a mask that you wear, and it forces air in and sucks it back out and helps people cough and clear their airways. So there is some, in addition to the sleep issues, there's pulmonary management as well to kind of go hand in hand.
How you chose and why you chose pulmonology?
That's a long answer. I'll give you the short version. I've always been interested in physiology, and that's kind of been my kind of, medicine-wise. I'm not a memorizer. I like to be able to understand principles and kind of derive from that. So critical care medicine is very much kind of internal medicine. People say internal medicine on steroids, so really sick people on ventilators, on drugs that affect the sympathetic nervous system. And there's a lot of physiology there, so it's fascinating. In adult medicine, pulmonary and critical care often go together. People who practice adult critical care often are also practicing pulmonology. Some don't. Some are anesthesia critical care. Some are surgeon critical care. But since I trained in internal medicine, pulmonary made sense. It also chose that field because, from my perspective, when I was in training, I liked a lot of things, and pulmonology, cardiology, critical care, infectious disease, and that kind of makes sense to do that in the ICU. Also, it's probably one of the most flexible specialties. If you're trained in pulmonary critical care, as I am, and in sleep, there's a lot of practice options. You can be an ICU doc, you can work shift work, you can work in a developing country if you want to deal with basic pulmonary disease, things like TB and others, or you can be an outpatient sleep doc. So it's kind of a very broad specialty. So that was one of the reasons I chose it.
Basically, I help them with treatment to try to increase the bone density of these patients, and treatment to prevent pain. Because there are some drugs that we use for the kind of the osteoporosis that they have for bone, and they have for pain. They help for pain, and so that's what I do. And also, it's very important for these people, physical therapy. This is the more they can do. I think the best they can do is physical therapy and something called water therapy. And for these kids, this is very difficult because, if you go to the pool, you jump on the pool and swim and play, etc. These kids cannot jump. So they need, in order to go to the pool, that place requires a special device that hold the child and put them in the water. And then depends on how he or she, many are boys, are able to function, whether that device hold them all the time, and then while they are in the water, they can move the legs or the arms. And that is very important, because the more they can do that, it's very beneficial for them. Now with COVID, everything is closed, it's a mess. So they do not have access to that therapy. UCLA, for a while, they used to have a special swimming pool for these kids that the program has developed. So, but it's also difficult because the families do not live close to UCLA and come here 2-3 times a week from an hour trip, and it becomes people work. It's very, very inconvenient. So but water therapy is something that I'm a strong believer that help these patients a lot. And I can tell you that's just mainly from clinical experience. I cannot tell you that there are randomized trials with more exercise or less exercise. That I cannot, but I can tell you I've seen many of these patients, and I see when I talk with the parents about, they tell me those who are able, not all of them, but those who are able to start this water therapy and aggressive physical therapy, they always tell me how much better they feel, how much, it helped them a lot with the pain, because you need to think about these kids. Some of them, they are sitting, have you ever seen a patient with Duchenne dystrophy?
Yeah.
Have you seen? So you see they're sitting in the wheelchair, and then the only thing that they do is the computer typing, and the very limited mobility. The legs, many of them cannot use their legs. And so all these kind of passive situations have tremendous consequence on your muscles and on your bone. For example, you seem like healthy individuals. So if I put you in bed, just for you, if you put you in bed for 3 weeks, your bone pay the consequence. You lose calcium, you have a number of immobilization is really very bad for bone health. Let's put it like this. And so this is something that it happened, that is a consequence of the disease. And then I see this patient mainly for this type of problem.
So I'm Stanley Nelson. So I'm one of the co-directors of the Center for Duchenne Muscular Dystrophy, as you guys saw. And I'm a physician, I'm a pediatrician by training, and I'm also run a laboratory that studies aspects of Duchenne. And we apply a few different approaches to trying to figure out new ways to go about approaching Duchenne. So, I've been working in the Duchenne field for now about 15 years. So, part of my world is organizing and building the team clinic structure that allows us to see kids that are really pretty complex. So the average boy with Duchenne, and it's mostly boys, but not entirely boys. So we do have a few girls in clinic who are manifesting carriers, who actually have and can frankly have Duchenne as well. So, on the clinic side, I helped organize a team of about 8 different people that see the patients in regard to, lung issues, heart issues, orthopedic issues, muscle weakness, how do we manage the drugs, what sort of drugs do we put them on, when do we decide to start steroids, how do we manage all the side effects of steroids since we're often putting them on for life. And then I also work to collect all of their clinical data. So we've created a clinical database where we try to capture how boys are changing over time, whether our clinic and other clinics are giving boys the care that's appropriate for this severity of disease affecting so many organ systems. So we try to hold ourselves up to, are we doing a good job, basically, along the way. And then we, try to figure out how to refer boys out from within the clinic if there's things that happen in Duchenne, but are not necessarily an absolutely core part of the disease. So a lot of the boys actually have language or cognitive issues or behavioral issues. And so we need to figure out if they have that and refer them out and sort of get them appropriate help in a variety of different ways. And then I try to work towards gathering biospecimens, blood samples, muscle samples, skin punch biopsies mostly, that are relevant for study in the laboratory. So for instance, would be the fibroblasts we've collected from actually well over 100 patients. And in theory, they can be made into pluripotent stem cells, and those can be differentiated into muscle, or they can be directly reprogrammed. So Carrie Michelli's lab can directly reprogram them into muscle, and then you can study them in the lab. Or we use those sometimes to ask about questions like, if we successfully performed exon skipping, can we make exon skipping better, more complete, a larger portion of the messages are skipped? And what are the molecular mechanisms that make that possible? And we collected biospecimens as well to sequence the genome of the kids. So most of the kids, we know the DMD mutation, so we know, what caused the DMD, and most of it's new mutations in that family. Pretty much everybody with Duchenne has a new mutation. Either it occurred typically in the mom, or it occurred in the child, who's the first person in the family affected, is by far and away the most common scenario. And then there's relatively few families where there's, sort of cousins that are affected and uncles, that sort of thing. But that also does happen. But, since every mutation is unique, they all typically result in a complete loss of dystrophin, as you know. But some of the boys, walk until they're 18 or 19, and other boys stop walking at age 8. So there's quite a spectrum of that. So we're sequencing about 300 boys who are selected from either walking a very long time or not able to walk at a relatively early age, and then looking for genetic differences that are outside of the DMD locus that might be contributing to, why they're progressing much more quickly and losing ambulation early, or why they're progressing much more slowly, even though they don't have dystrophin. And then we sort of just, consider various ideas. So we, years ago, it was pretty clear we didn't have enough muscle to look at, right? We weren't routinely getting muscle samples from Duchenne anymore. And it was, 30 years ago, before we knew what the gene was, everybody was diagnosed because of a muscle biopsy. And then once the gene was identified, you didn't have to muscle biopsy to get to a really complete and satisfying diagnosis. You could just do it with a blood test and DNA diagnostics. So clinically, that solved the problem, but you then lost the opportunity to study muscle in these boys. So we and others have been developing interesting new tools, but you want muscle to be able to look at. So a few years ago, we went about creating a relatively less invasive way to sample muscle with a core needle biopsy system. So instead of making a long incision in the skin and then look at the muscle and cutting some of the muscle out, which is, it's not a terrible procedure, but it's substantial and leaves a 2-inch scar in the kids. We can do that instead with a needle that looks, it's about the size of a pencil. So it's, it's not a tiny little needle, but, one can do that in you guys would tolerate it. A little tiny kid doesn't tolerate it, but so we've done a few hundred of those at this point to be able to gather muscle samples either before treatments, after treatments, and start to study how does the muscle respond when we start to have dystrophin replacement strategies. So we now live in a world where, boys when they're born have no dystrophin, they get diagnosed. And then many of those boys are now on exon skipping therapies, or they're on nonsense read-through therapies, and some are now on gene therapy, where they're getting a substantial amount of microdystrophin made in the muscle. And we now have the opportunity to study what's the cellular response of muscle and the actual muscle, the myofiber. How is it responding to having dystrophin restored? And then also, the muscle is not just muscle, it's fibroblasts, laying down the extracellular matrix, which then affects where the satellite cells live, the stem cells of the muscle. It then affects how satellite cells proliferate. There's immune cells that are in the muscle as well all the time. So if you get an injury, your muscle will die, but it will stimulate this massive expansion of stem cells that then result in repopulation and degradation of the collagen fibers in the extracellular matrix, and then re-expansion. And that actually can't happen unless you have an immune system. So the immune system is both damaging to muscle and destroys it, but it also, some components of the immune system, some components of cells that are infiltrating into muscle from the bloodstream, derived from the bone marrow, are actually mitigating the disease. So with Gary Michelli's lab, we're studying the single cell dynamics in muscle. So you can take these muscle cells, the muscle biopsies, tease out all the nuclei, and then study, what's happening to individual nuclei across tens of thousands of nuclei per muscle sample. So we basically try to look for ways to minimize harm to the kids in clinic in a way that maximizes novel discovery, and figure out how we can impact current clinical care and devise strategies for new therapeutics, right? Or how we might be thinking about how therapeutics are likely to fail or likely to be inadequate. So
our first question would just be if you would be able to describe your daily responsibilities and what sort of stuff you do as a nurse specialist.
Sure. So I'm a clinical nurse specialist for the California Center for Rare Diseases, which is headed by Dr. Nelson, who works closely with DMD. But the focus of our center is a little more than just muscular dystrophy. It's really for all rare diseases and improving care and access. And we're kind of still in our infancy, really. So I started with them. I'm one of only a couple really employees, I guess you could say, of the center last summer, or 2 summers. Last year seems like such a blur. I guess it was June of 2019. So it's myself and a patient navigator, and then of course the physicians involved in the center. So I help with coordinating blood samples or patients who might be appropriate to get whole genome sequencing. I help just set up programs, like we're expanding with the International Center, people that can even have access to some of our resources. We're hosting a virtual Rare Disease Day event this Friday. So kind of just some system improvement processes, building our REDCap database for data entry. I do a lot of that. I help go through, particularly with DMD, patients who might be eligible for some of our trials, and helping with the study coordinator, figuring out, inclusion, exclusion criteria.
We're really interested in how, what you do in a day and when you see patients. And the next question would be how do you collaborate with the rest of DMD healthcare teams, since there's several specialists who take care of a DMD patient?
Right. So the more accurate name for the diseases caused by DMD mutation is dystrophinopathy, meaning that any kind of disease caused by dystrophin mutation or so. So it ranges from patients with Duchenne Muscular Dystrophy, which is DMD, to patients who have milder phenotype, or Becker Muscular Dystrophy, and some in the middle, they call them intermediate. and also some manifesting carriers that even with ladies who have presentations of weakness, and also cardiomyopathy, meaning that they have a heart disease because of mutations in the DMD. So in all these patients have different needs depending on the severity. So in our multidisciplinary DMD clinic, the following specialists usually attend. We have geneticists. Dr. Nelson, for example, is the geneticist who is kind of our collaborator, and he has a lab and he does some research in DMD, some genetic phenotypic correlation and other studies, and also clinical trials. And there are some scientific investigations as to how mutations translate into like RNA transcripts and protein expression. So some of the basic science aspects are kind of covered by Dr. Nelson's lab and his collaborators and his network. That's one of the major arms of collaboration we have, and I'm co-principal investigator on some of the studies that he's doing now, with doing the biopsies and kind of trying to recruit patients. So definitely medical genetics is one part of our clinical care, providing also genetic counseling to families with Duchenne muscular dystrophy. We don't want, for example, to miss a lady who has a carrier of DMD because they may give birth to a Duchenne boy. That's one aspect. Then we also have cardiologists on our team. We have a pediatric cardiologist and an adult cardiologist. The pediatric, as the kids with Duchenne grow older in the teenage years or so, some of them develop cardiomyopathy, means diseases of the muscle pump function. They can't pump very well, and sometimes they get electrical problems in the heart. So we need to monitor their heart function with studying the way the heart structure is and the function of the heart with tools like MRI and echocardiogram, which is kind of the ultrasound of the heart. And they also need medications to kind of help cope with these. And some medications also help prevent these to happen or slow them down. So cardiology service is another service that collaborate with us. Are these kind of along with your question, or are you looking for some other answers? I have other collaborators that I'm going to talk about, but is that kind of the...
Yeah, it covers it's like interesting to hear about the broad, like people, like how many people are just involved in like taking care of DMD patients.
Yeah. And then we have pulmonology or respiratory doctors who are specialized in respiratory care. As Duchenne patients or muscular dystrophy patients get older, they run into troubles with sleep apnea, and the oxygenation or ventilation gets in. Their ventilation becomes impaired, especially first at nighttime, and then they progress. And they may also have restrictive lung disease, meaning that they don't have as big of a volume to kind of breathe. So they need to be monitored for that, and they need to be supported by machines to help them have a more healthy kind of ventilation. So that's why we have collaborators in pulmonology and sleep medicine. We're lucky to have a doctor who does both for us, like pulmonologist and a sleep medicine specialist who takes care of that aspect of it. People with muscular dystrophies develop deformities and weaknesses, and they need to be monitored for functional status. So we have physical therapy, physical therapists who attends all of our clinics to assess those needs. And based on their needs, kind of recommends things like wheelchair, using assistive devices, etc., and also teach them in the beginning to prevent falls and other things that they need to learn about. And then also, because of those weaknesses and deformities, etc., many patients benefit from braces. For example, if they have in the beginning or so, if they need special shoes or special braces for foot drop, meaning that their feet are weak or so. So we have an orthotics in our clinic also, who kind of guides patients how to get the best brace that they may benefit from. And as the mobility becomes compromised, as they kind of hit their early teenage or later years, they need a wheelchair to get around. So we have a wheelchair person, mobility specialist, who also, they have representatives going to their houses and kind of make some adjustments and try to get the best wheelchair depending on their needs. So that's one other aspect. The other thing we have is social worker. It's very difficult to take care of patients with muscular dystrophy as the disease becomes debilitating in terms of mobility, and they also run into health insurance issues and so forth. So our social worker helps kind of provide them with resources that they could benefit from. And also, some of those kids have cognitive problems. A percentage of patients with muscular dystrophy or Duchenne have cognitive decline or intellectual issues. And also, that's another way that social worker helps them to kind of use community resources to kind of for adaptive education and so forth. So these are the main kind of providers that we have in our ideal clinic. Some days, some people are not here because of COVID. There have been some kind of difficulties with having everybody. So we have been doing these video visits. Some providers work from home. So, so these are the elements of care that we have for the multidisciplinary DMD clinic.
So would you say, like, if you were to get a new patient coming in with DMD, would you say they would come to the clinic and like see everyone at once, or would you say this kind of plan of care builds up slowly over time?
Oh yeah, so that's another very good question, because patient needs differ, and some patients don't need to see everybody, and it's very frustrating to sit in the room and sometimes wait for all these people to come and see you. So actually, one of the major challenges we have is an optimal turnover of patients in the room. So we have them sit in a room, and they have these providers go in and see them and come out, and then the next patient comes in, the next provider goes in and come out, you know, just, and then so that's a kind of a challenge. But we try to prioritize. For example, say she doesn't need, or he doesn't need, for example, cardiology today, or he has his own pulmonologist. He doesn't need to see pulmonologists, and kind of we try to make these visits as efficient as possible, but it's a big challenge. So there's a nurse that tries to help coordinate all these cares and smooth, kind of streamline the day in clinic as well. Is that what you were asking?
Yeah. And then you said that you have like a clinic once every month. Could you talk us through like what kind of stuff you do for that, or maybe like what the routine is for like?
So for that clinic, we usually try to kind of highlight the needs, like for example, the studies they are supposed to do and they haven't done, or they are due to do. And then we try to kind of prioritize discussing them discussing those issues with the patients, because there are some standards of care that we try to follow for these muscular dystrophies, and depending on how old they are, they vary, and also depending on the severity of the disease, they vary. So someone who has a cardiac disease needs a more close monitoring of the heart. We make sure that they're seeing cardiology more often. If someone has respiratory problem, we make sure they see pulmonology more often or regularly. And some, because they also take steroids, there is some monitoring that we need to do for steroids. We collaborate with endocrinology and nephrology to help with their bone health. And also their orthopedic needs. Some of them develop scoliosis or musculoskeletal deformities that need to be addressed by an orthopedic surgeon. So we also collaborate with some orthopedic doctors at UCLA. And then we try to, as I said, it's sometimes hard to get everything done, especially in the past year or so, but we try to have them kind of combine the visits or combine things that they have to do in 1 or 2 days as much as they can. Some of them coming from not LA area, that makes it more challenging. You know, they have to commute, and that's another aspect of coordination of care.
Oh, wow. So you mentioned that you kind of follow along with DMD patients when they're first diagnosed. Would you say that in your specialty, you work very closely with other like DMD healthcare related like team members, or do you think it's mainly just, do they just come to your like side, and like, do you interact much with the other like physicians, I guess is what I'm asking?
They do both. Sometimes I see the kids in my own cardiomyopathy clinic. And sometimes I see, in fact, probably the majority of kids I see along with the neurologists in the multidisciplinary clinics. So there's physical therapists, there's neurologists, orthotists, social worker, different people that interact with them in that clinic. And so I see a lot of them in that clinic. Some of them have a little more need for more intensive cardiac treatment, and they come to my clinic. I see some kids with DMD who go to other neuromuscular clinics and then come see me. I see a few because I've seen them for clinical trials, and so I might see them outside of the neuromuscular clinic. So different combinations of that, but I do work with the doctors and the other providers in the neuromuscular clinic.
I guess if we were to focus more on like the DMD center, would you describe like the center as kind of like highly collaborative? Because I know there's like a lot of different workers. Like,
yeah, I think you know, first of all, a bias. I think integrated medicine is the way medicine should be provided. You know, the way we practice medicine now here is driven primarily by reimbursement, not by best practices. So that being said, the physicians, you know, before I would go to the clinic once a month on a specific day, you know, in person pre-pandemic, and there would be several patients, and it would be me, the cardiologist, you know, the neurologist, the orthotist, the wheelchair person, the physical therapist, so kind of everyone there at one time. Now, practically speaking, that's often a good visit as an introduction visit, or kind of just identify issues that need to be addressed. But often I end up seeing the patients independently in my own office, just because you know, we have our own respiratory therapist there. A lot of this is hands-on type treatment. It's not popping a pill, it's using these devices and other stuff. There's a lot of training that's required. So we can do that more effectively in our clinic in Santa Monica. But, you know, with now the pandemic and everything being virtual, and, you know, we are, I think, very collaborative. You know, Dr. Sultanzadeh, Dr. Shea, they have issues, they have patients they see, and it's not just DMD. You know, there's other muscular dystrophy patients that come along. You know, they'll send them to me, and vice versa. There was just a patient who was actually discharged from the hospital with a new diagnosis of myotonic muscular dystrophy. And, my colleagues are, I'm going to be, on the inpatient side, I'll be picking up on the outpatient side, and they referred to Dr. Shea's clinic because the person's actually never, seen, that kind of a subspecialist. So you develop these kind of, even if it's not a clear-cut pathway, it is very collaborative. I'm not involved very much in the research, specifically, just don't have the bandwidth to do that. But, the cardiologists, Dr. Hallman, and when they get to adults, if they are seen by the adult cardiologists, Dr. Cruz and others, we all communicate. Yeah, you, in this population, it's almost, hopefully they have a good parent advocate, but it's almost essential because, it's very hard to get people to do what I ask with a CPAP machine and a cough assist. It's already challenging. You might imagine it's particularly challenging in teenage boys, getting them to do something. And quite honestly, these boys, they're not idiots. They don't want to come and spend time with the doctor. They know that they have a fatal progressive neuromuscular disease, and they don't want to spend time talking to me. They want to get back and do what they can. And so it's a very different style of practice. It's, from my perspective, this is not complicated medicine for most of the time. It's very challenging because these aren't easy treatments, and the population can be challenging. I'll tell you, a lot of adult pulmonologists, just first of all, a lot of them didn't live long enough to kind of be under the care of an adult pulmonologist. So oftentimes people who lived into their 20s, their pediatrician was the only one who took care of them. And so that's actually why I got involved, is because they are living longer and we are able to support, especially with some ventilatory support early on. And as some therapies coming online, that it's really the goal of the clinic, and the goal of having us there was to be able to transition from pediatrics to adults care, and know that there was someone to, who was interested and capable of managing them, after they kind of aged out of pediatrics.
Now, obviously, for the management of this patient, you need a team of people, because it's a very complex disease. So the leader of the team is Dr. Shea. He is the neurologist taking care of this patient, but there are cardiologists, there are gastroenterologists, depends, the problems of these patients. So we tend to talk between each other when there are issues, and trying to by this team approach, what is the best way of helping these patients. This is, I think it's very important to keep in mind this team approach, that everybody, knows a little bit about the disease, and from their angle, they can, target the specific areas in which is the best way of helping them. So my job is really kind of helping them with the problems related to bone, and the bone and the muscle, they talk to each other. That's physiologically.
The next question is about the clinical trials. You mentioned that you are also a PI in research. I was wondering if being a primary care provider and being a researcher ever conflicts, and how do you feel about your patients being recruited into trials?
Yeah, so right now I'm mainly co-PI on Duchenne studies, but we discuss available. Usually the routine is to kind of find the best candidate for this study. So depending on, and we have to try to have no conflicts, because if they're on one trial, they cannot go to the other trial. So we try to think of what is best for the patient in terms of their inclusion, exclusion criteria, and try to decide if they're eligible. A lot of times they may not be eligible. One of the challenges is as they lose ambulation. In the past, most trials require ability to walk and so forth. So so we try to prioritize based on what has the most potential for them. In Duchenne muscular dystrophy, some gene therapies, for example, are very mutation specific. So you really have to have a specific mutation to be eligible for like a gene therapy. So that really narrows down the number of patients or so. And there are some more generic trials, meaning that they can apply to more people. I haven't had a problem with conflicts so far. But as I said, we try to make it, try to decide what is best for the patient to enroll them in the study that they potentially would benefit the most. I'm sorry, one other thing is we have to about potential side effects. So if we think that treatment in a trial would cause problems, we have to consider that as well, always kind of the risk potential benefits.
How could you expand on like the clinical trials? And if you feel like, is there any time a conflict between like being a primary care provider and being a researcher?
Usually there's not any conflict because most of the medications, as long as the trial was designed really well, usually a medication that's in a trial can just be added to the other medications that they're taking. And so you don't have to deprive them of some component of their, what we know will help them in order to experiment with something that we're not sure about. So it's a little bit, there's a lot less conflict if the trial is designed in such a way that it's just additive therapy, if they don't have to give up something that's already known to be helpful. Adding it in, sometimes there's a conflict between different trials where somebody might be the right age and have the right degree of illness, where they might be good candidates for different trials. And then sometimes helping a family decide if they're comfortable being in a trial, working with something that could be experimental, something that could actually cause them harm and not just good. Trying to make sure they understand the risks and benefits of being in the trial. A lot of DMD patients, because the disease is so severe and it's eventually going to take their life, a lot of parents are desperate to be in trials, even for drugs that might have only marginal benefit. And so sometimes helping them be realistic about what the trial might accomplish and what it might not. And then also just making sure that they're aware of the risks that are involved, because anybody can have a bad reaction to any drug for any reason. So making sure that they're well informed about that. But usually if you don't have to take away something that is good therapy for them in order to have them participate in a trial, there's not as much conflict. The danger is of some therapeutic misconception, that where a family thinks that if they're in a trial, they're going to be getting benefit. And so setting realistic expectations for trial participation is always important. That's one of the ethical sort of pieces about doing clinical research.
In kind of similar line, we were wondering if you knew of any research that you thought were kind of exciting, or like any new breakthroughs or new ideas that you might have heard of that you think are like interesting to share.
So there is a category of Duchenne muscular dystrophy patients with the stop codon mutations, meaning that the protein synthesis machinery reaches a stop mutation and stops making dystrophin. So one of the exciting studies that we did during the COVID, we kind of finished it. I kind of participated in the muscle biopsies, was trying to see patients who have been taking a medication that can try to kind of fool the protein machinery to ignore the stop codon. So this is a clinical trial that has been done And this is a medication that has been kind of used now and approved in Europe, but in the US, we have been waiting for this to happen. And it was very exciting for me to be able to participate in that clinical trial where we did a pre and post muscle biopsy to compare the expression of dystrophin in patients who have received this medication. The results, the study is closed, but the results haven't been reported and announced yet. But it was just something that is kind of exciting. If it works or helpful, that would help a group of patients with Duchenne muscular dystrophy.
Sounds really like cool.
Yeah.
I've not heard of trying to like ignore the soft codon and like manipulate the folding. That sounds very interesting.
Yes.
That's similar to like exon skipping.
Yeah, so it's not the skipping, it's not called the skipping, but it's the medication is a tolerant. It's been shown to help increase the expression of dystrophin by bypassing the stop codon, somehow trying to fool the machine protein synthesis machinery to kind of skip that kind of code. When we say exon skipping, we usually mean that we're trying to do something with the deletion mutations, meaning that we try to change an out of frame mutation to an in frame mutation. There's a rule in Duchenne muscular dystrophy that holds true in about 90% of patients with mutations, where if you have an out of frame mutation, your phenotype is very severe. However, in Becker muscular dystrophy, which is the milder version, you tend to have an in frame mutation. So with this exon skipping, they try to play with these exons and take them out, kind of not take them out, meaning but physically, but just try to have the protein machinery skip that exon so that the dystrophin that is made becomes in frame as a.
You mentioned that there's been a lot of innovation within the past like 5 years. I was wondering if there's any kind of like trials or research that you're excited about and that you feel like are going to be soon important clinically, and like what do you personally like kind of hope for, I guess?
Sure. I mean, I think everyone's hoping for I guess you could say a cure. I really don't, it's kind of a hard word to use because it's really unknown. I mean, I think everyone's hope, almost any parent right now, they're going to say gene therapy. You know, there's evolutions, different methods kind of, you know, they've talked about CRISPR, which is a little way off, but we have several gene therapy trials happening right now. Dr. Perry Shea leads most of those. We might start another one here soon, but I've definitely seen results with that, both muscular dystrophy and spinal muscular atrophy. So I think that that's, you know, remarkable and wonderful. I think what really is going to be, it's hard to say is equally exciting maybe, but I think it really is exciting is there's a lot of advocacy going on to change newborn screening. Really, it kind of varies by states. I don't know if you guys have gotten into this, but certain states have already started screening for muscular dystrophy at birth and others have not. So I think New York has and California has not. So kind of getting that, because some of these kids, you know, usually don't get diagnosed till 2.5 or so, I would say, or 4 even. And just if you could catch it earlier, you know, just kind of having those targeted treatments, and then, you know, maybe gene therapy or some of these options could just be available earlier. Or of course, you know, just encouraging prenatal testing if that's something that you want to do, depending if you're a carrier, and just kind of catching it even before. You know, we have families that have elected to do in vitro just to kind of avoid if they know that they are a carrier of muscular dystrophy, and that's definitely, you know, a personal decision, and I wouldn't say that's necessarily, I understand if people don't want to do that. It's certainly expensive too, but even just knowing if you're a carrier and that kind of preemptive, preventative, anticipatory I guess is the better word, care before the birth, I think is, or shortly after birth is exciting.
So, what is like the most satisfying part of working with the DMD community, and why did you choose to be a part of DMD healthcare team?
Yeah, so I have developed interest in genetics since high school, and my MD thesis was on a type of genetic muscle disease. And then I did 2 postdoctoral fellowships. One was in genetic myasthenic syndromes, and the second one was in a large series of Duchenne Muscular Dystrophy patients at University of Utah, Department of Human Genetics. So all of these kind of really make me excited to be involved with care of patients with Duchenne. And because of the complexity of their needs, and you need to be involved with genetics, with neuromuscular, with medicine, and all those aspects of care, it's been really satisfying for me to be part of the team and be able to help them as much as we can. And also be this molecular genetics, molecular therapeutics that have become available in the past few years are really kind of exciting and promising avenue for the future that hopefully we could really slow down the progression of these debilitating diseases. Sure, well, the word of wisdom is that you do what you love to do and be passionate about it, and just follow your interests. And I think the future of medicine is going to be more precision medicine, meaning genetics and immunology are going to be the most important aspects of modern medicine. So I would pursue things in those, and they're satisfying because kind of you can bring your lab and bench results to the clinic and hopefully see the results working for the patients. As for example, you have seen in the COVID vaccine that there are things that were done in the labs for a long time, but they were not implemented clinically. And then now, once all of a sudden, it shows how useful it can be. In terms of being involved, there are some Muscular Dystrophy Association of America, or MDA. They have some muscle walks across the nation. And sometimes you can do volunteer work there and participate and see patients who have muscular dystrophy and see the doctors or providers in those kind of activities and get a feeling of how it feels like, kind of be a little bit closer to patients. It's called muscle walk. I mean, since COVID, this has been not happening, unfortunately, but that's one of those activities that are interesting. The other thing is you could participate as like on a small research project with in DMD laboratories, like do some kind of lab work or some sort of a exposure to the lab research that is done in the you have at UCLA, we have a few labs that are involved in Duchenne, obviously, but at other institutions as well. Depending on where you are, you can get involved a little bit and see how things are evolving there also. These are the things I can think of. But if you, sometimes you can, I personally don't have a problem with somebody coming and like shadowing like a day of the clinic. Yeah.
Can you tell us how you've come to work with DMD patients, and why did you choose to specialize within the things that you're currently specializing in?
So I So I've been seeing patients in the DMD clinic for a long time. I started out because I was the cardiologist for the neuromuscular clinic. But the patients with DMD are just really interesting. And I had some research interests and collaborated with some collaborators for some of the therapies to investigate some of the therapies. And so I've just worked a lot with these patients. I've worked really closely with them. I've worked with their moms and their parents and caregivers. I've done some events with Muscular Dystrophy Association and other advocacy groups, lectures for CCS, things like that. So I've been doing a lot of education around the heart in neuromuscular disease. And the patients are just, they're nice, they're good to work with. They like to have somebody who understands their whole disease and not just the heart in their disease, because, you know, everything matters, not just one organ at a time. So a lot of the patients really appreciate the more holistic perspective that I can have because I've been working in that clinic. And then they're just really nice patients, and their families are great, and they just need some love and support. And they're usually really appreciative of anything and just the support that they, you know, have. It's not like their disease is something that's going to be cured anytime soon. And they recognize that. And so they just want somebody to, you know, take the journey with them and be comfortable on the journey along with them.
Would you say that working with DMD patients is more like unique or more fulfilling compared to other patients? Or how in other ways, how do you think like working with DMD patients are like different?
They're more, a lot of patients with cardiomyopathy. I have a lot of patients with cardiomyopathy who have other disorders. But the patients with DMD, usually the cardiomyopathy, until it's really late, is not the manifestation of their disease that they are the most concerned with. You know, they're very concerned with walking and not walking, and that usually consumes the families with the younger patients. And so having somebody who just knows what they're going to be seeing ahead of time, you know, keeping an eye on them and looking out for trouble, kind of relieves them of that burden. So I know what to be on the lookout for, and I know to tell them, look, you know, worry about the wheelchair, don't worry about the heart right now, you know. So I can be comfortable in that role, and I think that a lot of families appreciate just not having to think about, you know, everything when they're overwhelmed with, you know, bits and pieces as they go through their journey.
Could you go more in depth about how you came to work with the DMD Center, and what was your motivation in joining?
Sure. So, you know, as I mentioned, cardiology has a lot of subspecialties. And so some people open up arteries, those are interventionalists, and other people do imaging, but my specialty is just treating patients with weak hearts. And as you've learned already, you know, that is a common problem in patients with Duchenne. And so what happens is, as you know, these young men are living longer and longer because of the breakthroughs in terms of their respiratory treatments, we get to take care of them for their heart, because their hearts tend to become weak over time. And so we try to use the right medications at the right doses at the right times. And so because that's my specialty, I think, and also because I've had a relationship with some of the members of the team, it was, you know, a nice fit, and it was a great opportunity just to try to help in any way that I can. So unlike you guys, I would say I'm not a Duchenne expert, but I am a cardiomyopathy expert.
I noticed on the Duchenne website, the clinic website, that it said that you're an adult cardiologist. So would you say you see the adult DMD patients?
Yeah.
And you work with them. So you don't really you're not like, you don't really work with the younger kids, I guess.
Exactly. I mean, I think once the 18 and 19-year-olds, get tired of the colorful waiting rooms with rainbows. No offense to your rainbow in the background, by the way. Then they want to move over to. But sometimes I don't know what they're thinking. Like they might be like, "Oh man, this is way more boring." So they might want to go back. Dr. Halnon's pretty amazing. So so we I don't know if you met Dr. Halnon, but we work together. She often hands their care off to me, and I just continue a lot of the good work she's done. So
how would you say working with like DMD patients is like different from the people that you normally see?
Oh, that's really a great question, because I think the things I'll share with you are, you don't often see them in the review articles. You don't see them in the textbooks a lot of times. And so it's kind of neat because now I can tell you after doing this for a decade or so, like, oh, wow, it really is very different. And I guess, typically when I'm taking care of adult patients, many of them are older, first of all. And so they're either, a different phase of their life. The Duchenne young men often, it's really, you're working with a family, right? It's not just, but not always. I mean, there's some very independent young men who don't come with their parents and things like that. So that's what feels a little bit differently. And, often by the time they get to me, if they're Duchenne versus Becker's, as you know, Becker's is a milder form. And so the Becker's young men are ambulatory often, though not always. The goals of care might be different, right? Where someone who has a cardiomyopathy without Duchenne might be thinking about being able to play basketball and just live go to work and hike and things of that nature. I think a lot of times, young men with Duchenne want those things, but they also don't want to be over medicated, so that to the point where they can't, focus on the things that whether they're going to school. They want to be able to keep their heart strong, but they also don't want to be, in a sense, you want to find the right dose of the medication. And a lot of times you can't get away with as much medication with Duchenne young men, perhaps because they haven't been as active. So they come to me in wheelchairs most often, as you know. I will say one other thing that's different. I mean, there's a few things that are pretty interesting from a pathophysiology standpoint that I've just noticed over the years. And, one of them is many young men come in with very fast heart rates. And it's not necessarily completely reflective of, how much congestion they have. So a lot of times with adults who have heart failure, they have very fast heart rates because their hearts are really sick and they're just trying to keep up pumping enough blood. But I think that just being wheelchair bound a lot of times will drive the heart rate up very fast in the Duchenne young man. That's very different. Often their blood pressures do tend to run much lower. Again, partly because they don't have the venous return from standing, and just, they're often in a position where the venous return isn't very good. So it's often the challenge to use the medicines that we want to use, even with the heart's not that terribly weak. So you have to get, creative and in terms of how to start them, and work with, caregivers or whatever facility they might be in, just to not skip medicines, because a lot of times it's easier just to skip things when like, oh, the blood pressure is 82, maybe we shouldn't give it, and so it's like a lot of not haggling, but just a lot of persistence with just saying, okay, as long as we want to protect the heart, we don't want to overdo it, but we don't want to skip a lot of doses. And so it's I find that even though there's some overlap there, it's especially so with young men with Duchenne.
Why did you choose to work with DMD patients, and how did you come to do what you do right now? And what's the most satisfying part of working with this community?
Yeah, so my route into this is fairly personal. So when my younger son was 3, he had a surprise diagnosis of Duchenne. So I was working on genomic technology development, and Dylan's mom was running a completely separate lab. And when Dylan was diagnosed, it was really quite clear that sort of the care structure in the US and at UCLA in particular were not well structured. So I honestly felt an obligation that if I was going to coordinate this for Dylan, I really ought to be coordinating it for every other child diagnosed with Duchenne, given that it's a relatively common rare disease diagnosis. So that pulled me into the Duchenne area from what I was doing previously in really cancer and genomics to work in Duchenne and in rare diseases, but using genomic approaches. So a lot of things that I'd been doing in my 15 years of career prior to that were pretty easy to move over into this new area. So, and then, it's all about team building. So, this center that we created and we started a few years after Dylan's diagnosis in 2007 was really all about how do you empower ways to teach people better about Duchenne? How do you create training programs that at least don't ignore rare diseases like Duchenne, but embrace them as solvable problems? So certainly, the core attitude of genetic diseases, as we were solving them with linkage mapping and the Human Genome Project and positional cloning, was, boy, you solve that genetic disease, that's a terrible genetic disease, you're going to die from that genetic disease. Not really therapeutically much you can do. And I think that's been, demonstrably proven to be really a false narrative, and that, understanding in this rare disease, particularly rare genetic disease, understanding the exact mutation that caused DMD and the exact mutations that cause Becker muscular dystrophy, a much more mild disease, led directly to the approach of, if we can make a little bit of dystrophin, whether it's microdystrophin or whether it's exon skipping or nonsense read-through, you can mitigate the disease. So it's really, all about, could you build the team in the clinic that would make care for the boys more effective? Would that let us get samples and organize research teams to tackle substantive areas in Duchenne? So that's been, I would say building those teams and letting creative, thoughtful investigators go to town with their own unique insights, brilliance has been the most satisfying part.
So you mentioned that you were working in like the cancer field before, and I guess I was just wondering, is there like a big difference? I guess there would be a big difference, but like working closely with DMD patients compared to like cancer patients, is it, you said it was like kind of similar, but what are some of the, like, do you find it more interesting or like kind of just a different field that's like?
It's very different. I would say part of the reason I went into oncology, again, 30 years ago now, was because it was a field that at the time took an aggressive stance towards treatment. It wasn't, oh, you've got a lethal cancer, we're not going to do that much about it. It was a field that since the 60s has, iteratively developed therapeutics, so that, there was certainly a period where most kids with a cancer diagnosis died. That was the case in the 60s. And by the time I was choosing oncology, the majority of kids survived with childhood cancer. And at this point, about 75 to 80% of all children diagnosed with cancer survive through, iterative hard work of clinical trials and, innovative therapies, et cetera. So that was sort of the mindset that I came at it with. When I got into the Duchenne field, I was quite honestly appalled by the quality of clinical trials, the quality of how people were moving ideas and thoughts forward. And, it really required a far more ambitious, aggressive approach to doing clinical trials. So people were doing boutique-y clinical trials where they'd get 10 people in and they do some nutritional supplement this versus that, really unlikely to work. And so the field was littered with trials that were too small, trials that were therefore not well powered, trials that were ill-conceived, trials that were not effectively targeting the fundamental defect, and being done in a way where it was actually rather difficult, for one clinician in one location to be doing exactly the same thing as another clinician. And so, one of the eases of cancer work was, there was, we, for better or for worse, the core metric is, did somebody live or did somebody not live? Did the cancer come back or did the cancer not come back? Really, those are sort of the two metrics that are used in cancer clinical trials. So pretty concrete, right? It doesn't create a lot of creativity to say, you died, and that's a fairly defined point, right? But we can't do that with Duchenne because even though it's a lethal genetic disease and we know it at age 3, 4, 5, on average with current reasonable care, the boys are living on average until 25. So if we did a study which pushed back, even a survival of 10 years to 35, that would be great. But that's a 50-year study. It'd be an intergenerational study, which would be impossible to do, right? So you have to have some other measures to do. And so that's probably the biggest difference, was helping the field to organize around the idea that you really have to come up with robust clinical measures that allow you to robustly look in this area. The other part was coming up with meaningful surrogate biomarkers. So dystrophin is kind of the quintessential surrogate biomarker, right? You're as a boy with Duchenne, you're born without dystrophin. If you restore dystrophin, you should be able to measure dystrophin in the muscle, right? So this kind of gets back to this issue of, you have to sample the muscle, you have to see it in the muscle, you have to have tools and measures that can observe dystrophin well. But if you see some dystrophin and it's expressed at the right location, and it's and the muscle histology is improved, it's very reasonable to predict that there's going to be a clinical benefit that might be hard to see in 1 year, might even be hard to see in 2 years, but over a very long-term trajectory, there's a very high likelihood that there's a therapeutic benefit. So those are, some of the, really rather dramatically different sort of approaches that kind of the cancer field takes versus a rare disease field. But the beauty of Duchenne is, we know the exact target, right? Versus when you're even dealing with childhood leukemia, it's rare that you know exactly the mutation that caused the leukemia. There's a few leukemias where we know exactly what it is, but that's pretty rare. I mean, it's, the satisfaction that you can give back to parents to say, this is what caused your child's leukemia, or this is what caused your child's sarcoma, or this is what caused your child's brain cancer, is pretty much not there still, right? There's some instances where we can figure it out, but they're more rare than not. But in the Duchenne world, we always know exactly what caused it, and that every cell is missing dystrophin, and therefore you kind of have you have a tractable way. And the other very optimistic part is it is a very slow moving disease. So you have many years to mitigate the disease process, versus in cancer, you may sometimes only have months to effectively mitigate the disease, or the patient is lost. So quite different disease spectra. But I'd say the major thing when I entered it was a real lack of urgency in the field, and that's changed now. And I think you'll see that in your class, that there's a vast number of people engaged in clinical trials, both on the patient side and clinician side. They do clinical trials much better, far more rigorous way. And it's okay when clinical trials fail, right? If a drug doesn't work, it's a good bit of information, right? It's sad, didn't work, but it was not going to work today, the same as it's not going to work 5 years from now. So you might as well know it now rather than 5 years from now. And I think the field has matured in that way, right? With the idea being, don't drag things out forever. Try to get really crisp answers and be done with them. So.
How did you choose your professions, and what led you to work for rare diseases, and what led you to be involved in the DMD center and the rare disease center?
Sure, I'll try to do this as briefly as I can. So I'm from a pretty medical family, a lot of physicians and nurses in my family. So I guess I was always kind of drawn to nursing in that way. I was never never interested in being a doctor, really. I don't really think my mind could process all of that. But so I finished nursing school. I'm from Missouri, so I went to school out here at Mizzou, and then I worked as a traveling nurse, which is what brought me to California, where you get to take short-term assignments, kind of check out areas, which then kind of led me to Children's Hospital Los Angeles, where I was a hematology oncology nurse, which isn't rare disease exactly, but through that, it kind of sparked my interest in research, just because you would have kids that would relapse or get a secondary cancer, unfortunately, and sometimes they'd run out of treatment options too, and they would get put on a trial. And I just found that really interesting, you know, so I looked around, how can I get more involved with these research trials, which brought me to UCLA. So I worked in we have a clinical translational research center, and maybe some kids in your class might have been involved in this thing called a RAP student. It's like a research, I don't know what it stands for, a RAP student. And they go through and they work in labs and they volunteer some time just shadowing in the research center. So, you know, we had hundreds of trials come through there, basically where the answer is never going to be no. You know, these are people that had glioblastomas or muscular dystrophy, and that there is a new experimental drug. And so we were responsible for giving those infusions. And it was during that time that I decided, hey, this might be a good opportunity to go back to school, since I was working kind of more normal nursing hours, like 8 to 5. So I started taking school to do my clinical nurse specialist, which is basically where you learn how to just change system processes, kind of like what I'm doing now. And then you work on patient education and nursing education. So whenever I was about to finish, I had a little less than a year left, this position posted for the Rare Disease Center. And, you know, my current boss recommended me for it. She knew Dr. Nelson pretty well, and I talked to him about it. I'd already worked on a lot of the Duchenne trials, so I was kind of familiar with the population. So that's kind of how I got into that world. I mean, my background is pediatric nursing. It's mostly all that I've done. So I really have an interest in just helping people out. And like I said, that the answer is always going to be, we're going to do everything that we can.
Thank you. What is unique about working with DMD patients versus like other kids that you've been working before?
Yeah, I mean, it's kind of, there's some hopeful things. There's also some, it kind of is going to depend on the person's perspective, I think. I mean, it's really hard, to be honest, that you know kind of from a young age that your child is destined to this early death. You know, whereas pediatric oncology, for instance, maybe they had a 60% chance of survival from one of the worst cancers, which sounds like, you know, pretty bad news, but some of these really rare conditions like DMD, you kind of know from our early age, you know, especially a decade ago, like there was 100% chance, you know, your child would be dead before the age of 30. You know, now there's all these innovations in the last 6 years probably is really when, you know, exon skipping started coming out and gene therapy became a possibility. So I guess what's different is just that there's really a lot of parent rallying and information. You know, I'm pretty impressed. They have these conferences every year through Parent Project Muscular Dystrophy. And I've never even really heard of a conference like that before, where families attend, you know, and listen to scientific lectures. So I think that that's pretty unique, and that there's just so much support, and so many parents have started their own, you know, advocacy groups. So I find that pretty refreshing, and people are generally pretty knowledgeable. A lot of the parents really understand probably a lot more than, you know, I wouldn't say more than the doctors, but then, you know, maybe some other people working on certain aspects of their care team.
And you don't have to answer this question if you don't want to, but could you talk about how you process working with like patients who are critical or DMD patients, since it's incurable and lethal?
Yeah, gosh, you know, I think that You know, to be honest with you, there's more similarities than you think there, because I think by the time patients are coming into our clinic, they're very advanced in terms of even the non-Duchenne people. Many of them have, you know, less than a few years to live, less than a year to live. So we're often really fighting to keep them alive too. So I don't see that as you know, I don't see that as different a lot of times. But it's true that there's differences in the things you can offer them. Like, it's, even though it's been done in rare cases, we don't transplant patients who are unable to mobilize, right? Because it affects wound healing, and often there's skeletal issues, you know, whether it's kyphosis and scoliosis and things like that, that can affect just major surgeries. And so I guess it's like, the difference is that you don't have options on the table that you otherwise would sometimes. And so that's a bit, you know, very different. But I also think that by the time they come to me, they've wrestled with that on their own for so long, right? That it's not, even though I have had the experience and the privilege of helping families through that, you know, it's almost like they're more prepared than anybody because they've thought about it for so long. So I don't think that, you know, it's not as difficult as one would have imagined, perhaps.
And you don't have to respond to this one, but I was wondering, like, how do you process working in like critical care, especially like the DMD patients whose illness is incurable and most likely lethal?
Yeah, it's challenging. In addition to, I mean, critical care is challenging. Medicine itself is can be emotionally demanding. Critical care certainly is. You know, end of life issues, ethical issues, dealing with that in that group. I'll summarize by saying that I've had my own personal experience with medicine, and when I was young, and going through that, and multiple people in my family, and really one of the things that the reasons I did the DMD clinic is they kind of reached out to me, and my eldest son has serious medical issues, and so it was a large part because it was a need that was there, and because of the other physicians and parents that are there, you know, understanding, at least having some sense of what they're struggling with, and being able to kind of, you know, address it on a way that wasn't just a professional understanding, but a personal understanding. So that's how do I manage it? Wow. Lots of therapy and lots of exercise in the punching bag. And I actually helped lead kind of the development of Schwartz Center rounds at UCLA, and we started that in Santa Monica, and now it's at Westwood. It's kind of a national program that is intended to focus on provider well-being and kind of maintaining, you know, resilience, you know, in light of what we do. So, you know, I think I'm a big proponent of that. I think we have to recognize our own humanity, and I think a lot of medicine, especially Western medicine, and how it's been trained, has not taken that into account. So,
yeah, I would assume that working closely with these DMD and other like rare disease patients are kind of rough, maybe like hard on like doctors and nurses, like mentally, also like emotionally exhausting. And just like, do you have any ways of keeping track or like keeping care of your mental health? Just like, you know, processing things properly, or like, do you think it's kind of difficult in this field, I guess?
Yeah, I mean, I think that's a little dependent on the person. I mean, I can say in nursing school, I know one of my good friends just was like, I can't like handle this. I mean, I will say being a mom myself, I used to work all kinds of things. I used to work in the pediatric ICU. And I don't know if I could really imagine doing that right now, having my own kids. So I think some of it kind of depends on what's going on in your own life. I mean, both of my boys were born early, and I was in the neonatal intensive care unit with each of them for about a month. And that was way, way harder than I ever thought it would be, just being on the parent side of it. But I also think really it kind of helped me to be a more connected nurse, really. Sometimes I see, I don't know how much this happens with doctors, but I think it does, and nurses too, that you can get kind of caught up in the just, I don't know, kind of regimen of how things are done, that it's hard to, you can lose connection kind of easily with the emotional part. You know, you just say, oh, the social worker would deal with this or what have you, because you're just kind of used to it. You know, it doesn't mean the same to you. I hope that sounded not insensitive, but basically what I'm trying to say is that, you know, you can get used to it, and certain things that are certainly a heartache to families, such as, you know, your kid has lost ambulation, or your kid needs to go on a breathing machine. They're definitely hard words to deliver. I think what makes our center so unique, you know, I don't think this is a secret. I think maybe you've discussed it in your class, but Dr. Nelson and Michelle's son has muscular dystrophy. And I really, you know, I think people really appreciate that he's coming in that room and really cares about them, and kind of has that connection. And although my children, you know, don't have serious issues that I'm aware of, there is kind of something about, you know, just having that on your team, I guess, that person, or just having experience with being a mom yourself, that kind of, in my opinion, helps you bond a little bit with them.
Could you expand on your experience working with their families and like interacting with the parents of DMD patients?
Yeah, I mean, I think that, you know, and from what I've gathered, young, you know, patients who have had an illness for their whole life have a very unique relationship with their families and with their doctors in general. It really is a unit. I mean, it takes such dedication on the parent side to care for someone who's been ill from such a young age, that it really is a partnership. You know, I can't say, I mean, I don't have a partnership with my patient's parents, right? But this is genuinely, like in general, right? But this is more often than not a real partnership, even when they're adults, you know? And so the conversations often are with the parents in the room, even though that's not the case with other patients with terminal illnesses. But even that, I mean, I still think that they're young men, and sometimes older than young men, you know, that have a very strong opinion about what they envision for their life and for their death. And we also have times when it's just the patient and myself, and so the parents are not always involved in it. But I think that you know, I think that they know this young man better than anybody. So I think what they have to say needs to be taken into account. And you know, I'm trying to think of a single circumstance when I didn't think that they had their best. I just have never come across that. I'm sure there are cases, but I just haven't experienced that. They really genuinely have their best interests in mind. And sometimes, you know, like an area where that comes up is, you know, you may have heard of things called defibrillators or implantable cardiac defibrillators, ICDs, which are very common. They look like pacemakers, and they simply are there to monitor usually, and then if you have a deadly arrhythmia, it fires, right? So, you know, one of the difficult decisions is when the heart is getting weaker, you know, how do you make that decision on whether you offer a defibrillator to rescue someone's life, right? Because, you know, it's a harder decision with Duchenne, because, number one, you should have a pretty good prognosis. Sometimes the prognosis is borderline. Number two, the surgery itself can be a little more traumatic if they don't have enough muscle or if they have skeletal issues that can cause healing problems. And I think number three, you have to just wrestle with goals of care, right? And what are we don't have any randomized trials to answer this question. Like, oh, we've studied 1,000 young men like this, and this is the result. That doesn't exist. So you're using a lot of, I would say judgment, but also joint decision making on what makes sense in the particular phase of their life. So, yeah. So I guess, and it doesn't always make sense to proceed with a defibrillator, even if they're otherwise, young and would qualify.
Could you expand on your experience with families and parents of your patients?
I of course deal with the parents when we're talking about the treatments. I am a specialist, so I'm not kind of their primary DMD physician. Sometimes they have someone at the center, sometimes they have their own private physician, but yeah, I mean, oftentimes, especially the younger kids, I usually, if they're preteen, I kind of prefer that they see the pediatrics, but once they're kind of teenagers, it makes sense for me to be involved at that point. And so I say that because in some cases, oftentimes the interview is with the parent speaking for the child. I think all of us try to, of course, allow for that, but then try to engage the child, engage the patient as well, and get them interested. And it's, as you might imagine, just the wide range of human beings and personalities. There's a whole wide range of, parenting styles. Some who really are exceptional, kind of amazing type of people who despite the challenges that they face, are profound advocates for their children, and really kind of do everything they can to give their child the best quality of life possible. And there's other parents who are just it's, especially when they see me, it's because I'm the bad doctor in some ways, because I'm the one you see when things go bad, because if you're really sick, and the idea of a ventilator, and I don't know if you all are familiar with the tracheostomy tube, and so when they see the pulmonologist, they're already kind of primed that, oh my gosh, we're getting to the point where we're going to talk about this. So there's a lot of anxiety there, and the families deal with it in different ways. Certainly you see the whole variety. So I deal with them when I talk about the specifics. I do not get into goals of care discussions. Kind of what level of care are we going to do a tracheostomy or not? Certainly, if family have questions or patients have questions, I'll address it and I'll answer it. But because there's kind of a center, they have a social worker, there's, kind of a more complete picture, I usually let the primaries handle that, or I ask them to handle it. And then I just kind of focus on my specialty. There's some parents that, as you might imagine, they're in complete denial. They're just like, oh, he's fine. He's not going to have any respiratory problems. We've been doing fine for years. We're just going to continue to do fine. We don't need your help. And, you can't force anyone to do anything. So, it's you see the whole range.
What is your experience working with the families or parents of your patients? And since your family is also part of the DMD community, I was just wondering if you could talk about the difference of perspective from the parents and like the families and the doctor perspective and the researcher perspective.
Sure. Yeah, it's very rewarding. I think there's lots of upsides to it, but it's a difficult disease, right? We don't have highly effective therapies yet. So it's a disease where you have to manage expectations, and there's a lot of there's a lot of magical thinking by all of us, right? Of, hope being influenced by sort of unrealistic expectations of how fast research moves, how fast we might be able to implement new therapies that are going to cure our sons or even dramatically treat them. So, I'm in a bit of a unique position. And I think there's sort of legitimate hope to extend to the families. There's a lot of coordination of care. There's a whole lifetime of shift in the disease. So I spend a lot of my time essentially structuring for parents, that it really is a marathon, and everything that we do for kids that are at 4 or 8 or 12 or 16 or 20 or 25 are all intended with a view towards optimizing health decades later. And that's difficult to get across at first. So I think there's a strong sense of denial early in the disease because kids look pretty healthy, right? They do not look like they've got a lethal genetic disease. They're running around often. And, we can do some of the things that make them look apparently better in pretty short order. And that gives sort of a strong sense of, maybe it'll be much more mild than the doctors land on. So it's, I'd say most families from, certainly 10, 15 years ago, and probably still today, object to kind of a medical nihilism, but the idea being, you're born with a terrible genetic disease. There's not much you can do about it. The sort of attitude of take your home son and love them because you're not going to have that much time with them is really quite disturbing to most parents, right? I mean, there's a truth to it, but it's not really what any parent wants to be hearing, right? What a parent wants to be hearing is, this is a serious disease. There's a lot of issues that are going to come up, and we're going to do our best job possible to mitigate all of those. And it's not perfect, but we're going to be working hard to make that happen, versus there's not much you can do. So I'd say that's, probably a place where, we can have a fairly big impact in terms of affecting how families view what's otherwise a very difficult journey for them. And the families themselves build a community, as you could well imagine, right? It's sort of a club that you enter. And not everybody deals with it the same, wild differences, but people find kind of the community that's helpful to them in managing.
Could you talk about how your practice got affected by the pandemic, and what are your current practices now because of it, and how you accommodate the situation right now?
Well, in some ways, going back to Anna's question with, using the medications kind of preemptively means that if I don't have an echocardiogram, it doesn't matter because I'm going to be giving the medications even if the echo look normal. And so if I can't have an echo that would be done in person, then I can just, do visits on video. So I've been doing a lot of Zoom or Zoom-like medical visits by telemedicine, and just mostly following any symptoms or side effects of the medications and then just prescribing them, and just doing it without actually having the hands-on, images. There's some patients who've been comfortable coming to clinic and having echoes and things like that. And there's others that just aren't comfortable coming to our center to have an in-person visit. And so I'll do some by telemedicine, some in person, and just work with what people are comfortable with.
Yeah, a lot of doctors mentioned that they like the advantages of telemedicine and think that some of it will stay after the pandemic. Do you feel like you're going to incorporate more telehealth after it's not necessary anymore?
I like it. It's sometimes nice to see the kids in their own home. You can see how they're how they interact with their siblings. You can see how they interact with their house. You know, in our clinic, it's, you know, kind of a sterile environment with a with like furniture that's, you know, a certain size, and kids in a wheelchair who can't move around too much, and, you know, things like that. But at home, you can see how they interact with their environment. If they don't remember things about their medications, they have them there and they can show me the bottles. So things like that are sometimes really helpful. A lot of times the kids are more comfortable at home. And so talking to me by a video when I'm not going to touch them, if they're a little scared or nervous of, you know, having me touch them, or they're shy and, you know, don't want to see me in person. Sometimes they're a little more comfortable at home. So I think there's a lot of advantages to doing it. And I think a lot of the reason it wasn't done before was because you couldn't really submit a bill for doing a telemedicine visit. And so if you couldn't get paid for your visit, then you didn't want to do everything for free. So in the beginning of the pandemic, a lot of the insurance just switched over and said, hey, if you want to do telemedicine, we'll pay you for it. And we'll pay it kind of on par with what we would pay for an in-person visit, you know, depending on what actually you're doing in the visit. And so it made it much easier for physicians to be able to make a living by doing telemedicine. It made it easier for patients to, you know, get their visit paid for if they did telemedicine. And so since it worked well for the provider and the consumer, you know, it's taken hold. So I hope it'll stay. I think a lot of patients are more comfortable that way.
Would you say that the pandemic has affected your practice a lot? Like, has changed?
Yeah, you know, it has. It has. I think that, you know, we are doing things like this video visit that I had never done before. I mean, I would have never imagined that, you know, a certain percentage, I don't know what percentage, maybe 20% of my visits are on video, maybe 15%, 20. That's a lot. Going from 0 to 20% is a lot. So, yeah, so I think that's changed a lot. And then certainly, sometimes you just kind of decide, like, you know, maybe it's better to skip this visit. And, you know, usually depending on how they're doing, we might see each other every 3 months, every 6 months, every year. But, you know, we just either send messages back and forth and kind of decide maybe it's a good time to skip this visit, you know. So yeah, it's changed it tremendously and in a number of ways.
A lot of doctors have expressed that they see advantages of having telehealth. Do you feel like it's going to be a part of your practice even after the pandemic?
I do. I think it's going to be an important role, play an important part. How I would think of it is this: you know, if you're a patient that has a really hard time getting into the doctor's office, but you want to have, you know, a fairly good 20-minute conversation where you can, like we're having with your doctor, how else did you do it before, right? You had to kind of really make your way, who knows how many hours sometimes, just to get 20 minutes in the office. And I think that doesn't make sense for everybody, right? I mean, of course, the physical exam makes a huge difference a lot of times, and, you know, it's important, but that's part of the patient's job, and our job is to say, you know, this really should be an in-person visit versus having conversations that are more that are really not related to something that's physical. So I think it's going to be a really important part, and I think most of us are embracing it. Like, you know, it's just part of the new normal, and some people are going to love it. It's going to save them a big hassle. So,
do you think like the pandemic has kind of opened the way for more like telehealth?
Oh, absolutely. Absolutely. I think people who were hesitant or resistant, you know, by necessity have now had to adopt it. And I think through experience have learned what's good, what's not good, what works, what doesn't. it's not perfect. I can't listen to people's lungs via, but I can get a lot of other information, and it also allows for more frequent touches. We can check in with people more regularly if they don't have to make a huge trip. I have a patient, she doesn't have DMD, but she has an undiagnosed genetic disorder with significant respiratory muscle weakness, who I met after she was hospitalized. After that, we got her set up with non-invasive ventilation, cough assist, all of that. She lives somewhere in the Central Valley by herself, not with her parents, on her own, lives independently.
Wow.
And we had a video visit and she got COVID. And the question was, okay, what do we do? What's going to happen? Where can you go? And so thankfully she did okay, but it allowed for us to kind of just check in. How are you doing? Check in. Let me take a look at you. How are you feeling? We can check in again next week. And really, there's a lot, when you have a bit of experience, there's a lot you can learn just by looking at somebody. What's their respiratory muscle strength? What do they look like? Are they breathless with sentences? How much can they say? So, I think I think a lot of people who were resistant before are much more open to it now. Unfortunately, a lot of things in medicine are driven by reimbursement, and so there's horrible inefficiencies that still exist. But that's the system we work within. I was a big proponent of telemedicine before the pandemic. There's a lot that we can do via video, especially in my field. Sometimes the telemedicine visits are better than the person coming in real life, because these devices that they use are not small, they're pretty big, kind of things. And for them to bring it into the office and come in and have that time and to do all that, the parents to take time from work, it's a big deal. Versus, now they've got the device at home, they're maybe not 100% sure how to use it. My respiratory therapist in the office can do a video visit with them, show us what you're doing. And sometimes I've learned more with a video visit than I would in person, because I see what they're doing at home and I see what their setup is and how are you using it. And we can talk about things and save that kind of, time commitment and excursion. So,
any final message you would like to give for the students of PhySci121?
I guess like a quick question would be, how do you think maybe like COVID has altered your clinic, or like what kind of care you give right now?
Yeah, I was optimistic that doing more Zoom would be good. And it is good for answering quick questions, and it's very bad for giving coordinated care across multiple disciplines. So the full team clinic is really disadvantaged by moving to a Zoom-based clinic, a telemedicine-based type of clinic. But on the upside, we can provide a more thoughtful, legal, thorough visit with those who live in a different state. So I have some patients who travel to me from Alabama or Florida or New York, and I can see them. I can write a note, I can manage some of their care without them having to jump on an airplane and fly all the way here. So that part's gratifying. But for the patients that are here in LA who are coming, it's not, it's been very difficult to offer the same quality of care that's typical. I think we'll emerge from that in the coming months, of course.
Do you know how many clinics like the one at UCLA there are in the States?
Yeah, there's probably about 20 or so that are comparable. And UCLA is probably probably the third or fourth biggest such clinic, and one of the top 2 or 3 for doing research or clinical trials and care. So it's a reasonably unique clinic, but not completely unique. And then there's about 20 academic medical centers that have, really do work very hard to kind of cobble together the various subspecialists to provide care in a more coordinated way. So it's not routine in the US yet, and it's difficult to do. But there's a very good clinic in Denver. There's a very good clinic in Davis. There's a very good clinic at Stanford, up in Washington State, actually in Washington, DC, Columbus, Cincinnati, Boston. So there's, it's not like it's impossible to find, but they're not, not quite as numerous. Actually, it's dramatically less common than the number of children's oncology programs that I could name. There's probably 4 times as many really competent children's oncology programs than competent Duchenne clinics.
Do you collaborate with these other clinics in any way?
Yep. Yeah. So one of the projects that we're working on now is to develop a standardized set of clinical tools so that we can plot patients out in terms of how they're deviating from the norm of Duchenne. So you imagine a growth chart, right? We know when kids are growing slowly, we know when kids are growing too fast, because as you were a child, your pediatrician measured your height and told you where in your growth chart, right? And if you were deviating from that, we would know it. Same sort of thing we could do with a muscle disease, with the idea being as your muscle disease progresses, are you progressing unusually fast? Are you losing muscle strength more quickly? So that's a collaboration. We're working on creating a toolkit of really muscle strength measurements that are easy for every clinic to reliably get. And then for a system where we can post-clinic share the aggregate data such that every child could be plotted relative to the norm of all Duchenne boys. And then you get a better sense of where a given boy is in the overall course of Duchenne.
But we were wondering if you have maybe any message or words of wisdoms for the students that are taking our class who could become future doctors and researchers.
As far as advice goes for, just general care, is sort of it's always sometimes hard to think about what it's like to be, the family of somebody with chronic illness and how it impacts them, and how, kind of what a drain on resources it can be, time to take care of them. Especially DMD takes a lot of time because there's a lot of things that you have to do for your kids that just take, physical man hours to do, including, doing medical visits, helping them stretch, helping them move around, helping accommodate them physically in their environment. Takes longer to walk around a grocery store. Just a lot of things that just take up a lot of energy and time. And then also, how families feel about the idea of a chronic disease. And, in general, DMD is still a fatal disease that's going to, kill somebody when they're young. And, what it's like to see that coming from a long way away. It's, one thing to have a child get a sudden illness that's life-threatening, that'll affect them for a couple of years. It's another thing to, find out that they're affected when they're 3 or 4 years old, and know that, in their 20s or their 30s is when it's finally gonna, really finish taking its toll. And so how families, cope with that kind of thing. And so I always try to be aware of, what is it that I can do to make things easier for them. So like the telemedicine, it feels like it makes things easier for the family. And so we should just do it. Helping to make appointments, trying to combine appointments, giving medication in forms that's easier to do, giving medications just once a day instead of twice a day, so that they, get 5 seconds of their life back. Just that kind of thing, just being aware of what a toll it takes, and to try to minimize my impact on them, and minimize the impact of my recommendations on them, and make things as easy as possible.
Do you have any like final message for students in PhySci121 who could become like future doctors or researchers or other healthcare providers?
Yeah. Well, I mean, I think that first of all, it's I couldn't think of doing anything else. I know you've probably heard that before. I'm not very good at many other things, and so that's part of it. So, but I think that if you just really do things that you love, whatever that might be, right? And it just turned out that I loved immunology and I did an immunology PhD. I loved cardiology and I specialized in cardiology. I loved heart failure and transplant and I did a subspecialty in that. And it seems like it's just kind of fun, like work is fun. And I think that what I would say, whatever stage you're in, if you're really passionate about something, you're more likely to think about it more and be better at it. And so maybe that's my advice is just, yes, there's a grind to some of the things we have to do, but at the end, if you really are passionate about it, you're more likely to kind of become really kind of a master at it. Not that I'm a master, but like you want to become that, right? At least you're working towards that rather than just like clocking in and clocking out, right? That's not the kind of job that you want to be a part of. At least I want to be a part of that. So
I was wondering if you have any suggestions for perhaps like students or like undergrad students in maybe getting involved in the community or like helping in DMD in any way.
There's the center, the CDMD center, and it's very much most of these centers are kind of initiated or driven or at least kind of inspired by parents. And apart from looking for a cure and finding treatments, my experience is a lot of these young men, they're not just kind of waiting to die. They want to do things with their life. They're moving forward. A lot of them, going to graduate school or college and or working. And interestingly, a lot of them work, I don't know if it's just because where we are, but video game design and those types of things where you might imagine they're able to really give good insights and feedback. I think the biggest thing for undergraduates, and I think from a family perspective, is one, to understand what the families go through. Okay, and I mean that in a very, very basic sense. I at one point, I have strong opinions about a lot of things, but at one point, I thought it would be a good idea for medical students to accompany patients to their physician visits, almost theoretically, not necessarily just from the parking lot in, but what it takes some of these patients, what it takes them to come to the physician. And I say that especially because, getting into these big wheelchairs, getting up, the Hoyer lifts, coming for an appointment, that's a big deal. That's a lot of effort. And I've had cases where I've seen this, where patients were, a few minutes late. Nope, sorry, we're not going to see you. Or, and these types of, responses. And I think, and even the DMD clinic, coming and sitting down for several hours, not easy, not easy for a kid to come and do. So, I think in medicine, we need to, especially when it is highly, highly specialized care. I mean, you can't go to a DMD center at just any hospital. And traditionally at academic centers, it was kind of like, okay, I come, I wait for 3 hours, I drive 2 hours to get here, wait for 3 hours to see the doctor. That's fine, because this is the world's expert. He's the only person who can take care of me. We need to get past that. We need to start recognizing what is the experience of these individuals coming in here. I think understanding the challenges, the daily challenges. I think we all certainly, I would love to come up with a cure or someone to figure out a cure, but short of that, just what's it like to get through the day with this. And ultimately, these are teenage boys. They're ultimately they're just young men. They're, you know, that's let's not forget that part of it. And I think that they have rich social lives outside of some of them. And I think having a perspective on that would help us as a medical community be more supportive.
Yeah, that's really important. I agree with you.
Wheelchair access to buildings, you know, a ramp, an accessible bathroom.
Yeah.
You know, these types of very basic stuff that, you know, we take for granted. We take for granted. I don't have any great advice other than I think the advice that I've been given over the years is one is stay curious. And I would say for those individuals who really want to go into medicine and clinical medicine, think long and hard. Think long and hard. And I say that because to do the job well is challenging. You know, it's tough. It's tough. You can't not care about your patients. You can't have this shield and pretend like you're going to be impervious. It's going to be emotionally challenging at times. And if it's not, then I question whether that person should be a clinician, you know, taking care of patients. I mean, not everyone has to take care of patients. Some people do tremendous work and make massive contributions through, you know, discoveries and science, and we should go towards, you know, that which suits personality and our strengths. But for people who want to do clinical medicine, it's you have to be competent. You have to know the science. You have to know, you can't just be a nice guy who doesn't know anything. You've got to know all that, but there's another element, and that's that human element. And you know, one, if you're interested in doing that, you have to think about whether that's a road you want to walk down. And it's incredibly challenging at times, but it's also incredibly rewarding. And so if you're up for that, develop good self-care skills. I would say that was one piece of advice for everyone. Develop good self-care skills. Take good care of yourself. You can't do much if you don't do that.
Is there any kind of like final message for students of like PhySci121 who will who might become like future healthcare providers and researchers? And if you know of any, like, do you have any advice of how students could get involved in helping the community or learning more about DMD?
Yeah, I mean, advice. I mean, I think you guys are doing a great thing. It's really interesting that this course even exists, honestly. So I applaud you guys for that and your interest. I would just say, you might hear my 2-year-old out there, I apologize. I would say, you know, just keep getting involved, like that advocacy I mentioned, if you could, you know, really help other people be aware. Sorry. It's gonna ruin if you put it in.
Oh.
But yeah, I mean, if you, any opportunity just to educate other people, I think it's great that, you know, you guys have these awareness events. I think that's the big thing with rare disease, just helping to make people aware, kind of, you know, I don't know if there's so much a stigma or anything anymore, but you know, a lot of these people with rare diseases still have pretty capable and brilliant minds, you know. I'm always impressed by some of these kids that we have through our clinic that are going to, you know, become engineers or et cetera. So, you know, just never underestimating these people with rare diseases. And then I would encourage, you know, I don't know if you want to look on our website. We have a, not the Duchenne website, but rare diseases. .ucla.edu. It's diseases with an S. I kind of manage that website, so it might not be the most beautiful thing. I'm not really trained in websites, but we have a event this Friday from 1 to 3, our inaugural Rare Disease Day event. So if anyone doesn't have class or wants to tune in, there's a link on there. If you scroll down to the bottom where you can register, and several, you know, researchers are going to talk. There's going to be patient families talking about advocacy and just telling their stories. So I would encourage if anyone wants to attend that, please feel free to share that link with your.
And in conclusion, as you can see, treating DMD takes many different experts, and the process of treatment is lifelong. We hope you can walk away with a new perspective on the scope of treatment that someone with DMD might receive, and also hear perspective of professionals working firsthand with DMD patients. Thank you.
I was just wondering, right, like during this specific week, we've been talking about like the cardiac aspect of treatment of DMD, and we recently read like kind of a paper that went over like the standard of care for like heart disease like progression, and one of which they said was like they recommended doing like pre-symptomatic treatment. And but they also said that there wasn't like a ton of data that fully supported pre-symptomatic treatment, and it varies between like clinics and stuff. So I was wondering if you had any like what are your thoughts, or what kind of stuff do you practice, or is it like a case by case basis kind of thing?
Well, I always look at the heart in muscular dystrophy as already damaged before you're born, because dystrophin isn't there. So it's not like the heart works great and then later on there's something different about it and it doesn't work as well. It's the deficit of dystrophin is always there, and then it's just a matter of how much damage accumulates, that then you can see that the function of the heart isn't good. So cell by cell by cell by cell, if you have one cell damaged, you won't notice anything. If you have 90% of the cells damaged, you're going to notice that your heart doesn't work very well. So from the time you're born, your dystrophin is usually not there, and your heart is already different than somebody whose heart does have dystrophin. So that's why I always feel like if you start treating earlier, what you're doing, all the drugs that we use to treat the heart in dystrophinopathies, none of them actually change the heart itself that much. What they're doing is changing the workload of the heart. And so if you decrease the workload whenever you start, you're probably going to be getting some benefit looking forward. So if you start a little bit earlier, then you're just going to be preserving the heart starting a little bit earlier. None of the drugs that we use are going to prevent completely the heart from deteriorating. It's going to deteriorate anyway, but it's just a matter of how long it takes to have the decline. So that's why I usually start the medications pretty early, because the heart can deserve to have less workload as soon as you can offer it less workload, and it will help to keep it stronger. But it's not going to prevent completely the deterioration from happening. So I offer quickly, yeah. And some parents just aren't ready to give their kids medications for something that they don't see as a problem. By the time they're a little bit older and I've talked to them enough about it, then they're usually ready to hear it. The trials that show the benefits are like, you can number them on one hand. There's hardly any, and they all have, a small number of patients, like 40 patients. So all of that information is based on really small trials, a small number of trials in a small number of subjects, looking at a small number of outcomes. So, but it's based on the premise that the dystrophin was never there, and so the heart is already different than normal. And so just decreasing the workload should be helpful in theory.
Yeah, one of our assignments was to like take a look at how like the disease progressed and suggest like ways that you could perhaps like help or like make it more efficient, I guess, of like catching DMD. And one of which we were talking about was like trying to get newborn screening for like in all like hospitals or like every state for like muscular dystrophy. So yeah, someone was saying that it wasn't very like realistic since it was like a rare disease, but it's cool to hear that they're like actually people like trying to like that it's actually happening, like people are advocating for it.
I mean, and I don't know if this is part of your assignment or if you guys really wanted to. I mean, it's called Rare Action Network. So I think they have them in all states, but I know there's a California Rare Action Network because they just had a virtual event last week. And on their website somewhere, they have stuff linked about a bill that they're supporting to have this happen and how you can, write your senators or Congress people, kind of encouraging them.
Do you think the protocols and like the new ways of doing things that you're doing for DMD patients could be extrapolated and used for other kinds of disease or in other fields, like can be adopted for other research?
Absolutely. Yeah, so for sure, the way we do needle biopsies now that we develop for this Duchenne application is, at least in my clinic, is the standard for how we go about diagnosing all muscle disease. So I won't do an open biopsy again because the core needle biopsy gives me all the tissue I need. I can do it sitting in regular clinic. So that's sort of an example of we improve diagnostics for all muscle diseases by doing this in Duchenne. The other part where we shifted kind of the clinical realm, not along the therapeutics, but we also sometimes in a few percent of Duchenne boys, we can't find the DNA mutation. We know they have Duchenne, we know dystrophin is missing, but we can't find the DNA mutation. And that's a real problem because we can't tell whether the mom is a carrier. We can't tell whether his sister's a carrier. We can't tell whether his grandma's a carrier. So we can't really determine genetic risk in the family, even though we're telling him, boy, your son clearly has a lethal genetic disease. So we developed methods where you can take muscle, shotgun sequence all of the RNA, and then identify cryptic mutations that are affecting the RNA. And then we can work backwards to find the exact DNA mutation. And the reason that happens is, and I'm sure you've heard about this in your class as well, the DMD gene is over 2 million bases long, and a DNA mutation, in theory, anywhere within there could cause a problem. But the only ones we can easily interpret are those DNA mutations that are affecting the 13,000 bases of that 2 million that are the protein coding part. So we see a few percent of the mutations are deep intronic mutations. So a deep intronic mutation might create a pseudoexon. So you splice into the pseudoexon, it creates a stop mutation there, and you've screwed up. It's the same as getting a nonsense mutation, but it's through a very different mechanism. And those things do lead to sort of novel therapeutic insights, right? If you could splice out that little pseudoexon, you could theoretically repair dystrophin in that boy. But that general technique, we've now extrapolated to use across all rare diseases. So we, in amongst those who we can't solve by exome sequencing, we can now offer this type of RNA sequencing, again, similarly, try to find the deep non-coding mutations that are affecting the protein sequence. We can infer that it's affecting the protein sequence because the RNA is disrupted, right? So those are ways that, what we do in Duchenne sort of has a broader impact in pretty obvious ways. But it's also true, the exon skipping strategy that was first approved for Duchenne, approved in 2016, was the first exon skipping drug, second RNA therapeutic ever approved. The ideas behind that led to now 4 different drugs approved. This strategy is being used in about a dozen other diseases. It's not always relevant to every disease, but it's plausible to try it in other diseases as a strategy to kind of repair mutations. And then the gene therapy, similarly, muscle is by far and away, you have many more muscle nuclei than any other nucleus in your body, by far and away, in which case the challenge of trying to take an AAV virus and express that in as many muscle nuclei as possible opens a lot of doors for every disease, right? So if you can do this in the most abundant tissue in the body, it opens doors for trying to do this in many, many other rare disease areas. So there's certainly about to be, and there already is, but there will be, flourishing as and if AAV-mediated gene replacement in mature tissues like muscles becomes routine. It then opens the door. We have information about, can you give massive doses of AAV virus? How do you safely give massive doses of AAV virus? Are there differences in the different isoforms? Can you mitigate the immune response that might exist because children are exposed to adeno-associated viruses normally in our environment, and some have neutralizing antibodies. So regardless of the disease that you're treating, if you can't deal with those neutralizing antibodies, you can't safely give the AAV, whether it's Duchenne or for some other muscle disease or for a non-muscle disease. So again, dealing with the immune system to allow gene therapy to go forward will be generically related to every rare disease that we try to treat with AAV. Yeah, so a lot of these things are cross-fertilizing, right?